to you, sir.
Good evening, all. I welcome you all to the Image Journal Club on 22nd of February 2024. This year, as part of the Indian Myeloma Congress, we had two primary chapters, one on amyloid and one on Waldenstrom's, which have been inaugurated and made a component of the Indian Myeloma Academic Group. So as part of this year, we have been trying to concentrate on articles related to amyloidosis and Waldenstrom's macroglobulinemia. So today, we are going to discuss something about Waldenstrom's. Can I have the next slide, please? So we are going to discuss an article on the role of ibrutinib and venetoclax as primary therapy in symptomatic treatment-naive patients of Waldenstrom's. And to discuss this particular article, we have today from SGPGI Lucknow. Next slide, please. From SGPGI Lucknow, we have Dr. Aishwarya, who will be presenting this particular article. And to discuss it, we have Dr. Sanjeev, Associate Prof from Department of Hematology and Bone Marrow Transplant. And we have Dr. Pankaj Malhotra, sir. Everybody knows it. He does not require a formal introduction for this cohort of people who are attending this journal club. So we have Dr. Pankaj, the head of the Department of Clinical Hematology and Medical Oncology at PGI Chandigarh, who will be discussing this article threadbare after the presentation by Dr. Aishwarya. So now I would request Dr. Aishwarya to kindly share her screen and to start the presentation, please.
Thank you, Uday sir, so much for this wonderful opportunity. Let me just share my screen. I hope my slides are visible.
Yes, ma'am, it is visible.
All right.
Yes.
Very warm good evening to everyone present here on this August gathering. Today's journal is ibrutinib and venetoclax as primary therapy in symptomatic treatment-naive Waldenstrom macroglobulinemia. I would like to thank Image for this wonderful opportunity presented to me. My moderator is Dr. Sanjeev. This journal was published on 14 February 2024. It was by Castillo et al. So, brief introduction on ibrutinib. X-linked A-gamma globulinemia was first, when Bruton described this disease, he described this gene which was mutated causing X-linked A-gamma globulinemia. And this was as far back as in 1952. The first Bruton tyrosine kinase inhibitor was discovered in 1999, and further in hematology it was coming to use only by 2013 by Advani et al. In CLL in a relapsed refractory setting and other BNHL. It had a very good response, and then it was thought to be used in Waldenstrom macroglobulinemia. This was done in 3 studies from 2015 by Furman et al., Trion et al., and the Innovate study. Most of these studies were done in the relapsed refractory setting. It was found that it had a very good effect, especially in the MYD88 mutated and the CXCR4 wild type. Aspen was the first study in 2020. It was one of the studies in 2020 in which ibrutinib was used as a first-line setting and was compared with zanubrutinib in untreated Waldenstrom macroglobulinemia. Zanubrutinib had a slightly better progression-free survival and definitely a better side effect profile as compared to ibrutinib. So how is it effective in Waldenstrom macroglobulinemia? So myeloid differentiation primary response, MYD88 mutation that is seen in 90% of Waldenstrom macroglobulinemia. This protein is usually linked to TLR receptor 4 and interleukin 1. It causes dimerization when activated and then causes phosphorylation of IRAT4 and 1, which further leads to downstream NF-kappa B activation, causing cell proliferation and cell survival. Upon mutation, it is constitutively active. It also is noted that Bruton tyrosine kinase is also constitutively active as a result of MYD88 activation in a non-B cell receptor pathway. Bruton tyrosine kinase also further downstream causes NF-kappa B activation. So therefore, by inhibiting Bruton tyrosine kinase, we are effectively negating the effect of MYD88. So why venetoclax should be added to ibrutinib? Because BCL2 is an anti-apoptotic marker and is overexpressed in Waldenstrom macroglobulinemia cells, irrespective of their CXCR4 mutation status. So the synergism of venetoclax and ibrutinib has been seen in many trials previously, like in the Clarity trial of 2019, where ibrutinib was combined with venetoclax in the relapsed refractory CLL setting. Basically, one is a pro-apoptotic protein or molecule, and the other prevents cell proliferation and inhibition. Castillo et al. In 2020 proved the efficacy of monotherapy venetoclax in previously treated Waldenstrom macroglemia. So they postulate basically that by addition of venetoclax, there will be reduction of the effect of CXCR4 mutation status on the ibrutinib efficacy, causing better efficacy of ibrutinib, and probably also reducing the duration of the treatment to a fixed duration of 2 years only. So now let's get to the study. This was a multi-center, single-arm prospective trial. It was a phase 2 trial. It was conducted from July 2020 to January 2022. The data was collected till 31st May 2023. The centers were Dana-Farber Cancer Institute, Massachusetts General Hospital, and Beth Israel Deaconess Medical Center in Boston. The inclusion criteria included patients of 18 years or older with Waldenstrom macroglobulinemia as per the IWWM2 consensus criteria. The patient should not be previously treated. They should have a good performance status of less than or equal to ECOG 2. They should also have a bone marrow function. They should have a relatively good bone marrow function with a neutrophil count of more than 1,000, a platelet count of more than 50,000, and hemoglobin of more than 8 gram per deciliter. Creat clearance should be more than 50, and the hepatic function should be good. Even after this adequate bone marrow function, they should still meet the IWWM2 criteria to receive therapy. So they took patients with relatively less cytopenias. Exclusion criteria included MYD88 wild type mutational status, central nervous system involvement, other viral infections like HIV, hepatitis B, C, concurrent therapy for other cancers, cardiovascular diseases, or medications that could cause prolongation of the QT interval, current pregnancy, or breastfeeding. So this is the consort diagram. 45 patients were enrolled and allocated treatment to ibrutinib and venetoclax. Out of the 45, nearly 40, all had early termination. I will come to that later on, why there was an early termination of this study. Adverse events were noted in 4 and progressive disease was noted in 1. Only 40 continued till follow-up. The primary endpoint was assessment of VGPR. Many studies previously have proven that attainment of VGPR does coincide with a better PFS, and so they took this surrogate marker instead of progression-free survival. Secondary outcome measures like overall response rate, minor response or better, major response, time to minor response, time to major response, time to VGPR, time to next treatment, PFS, OS, and drug safety were taken. So the treatment they gave was 28 days cycles were used in an OPD setting. In cycle 1, ibrutinib was given at 420 milligram per oral once daily. From cycle 2 only, venetoclax was added at 100 mg for week 1, 200 mg for week 2, and 400 mg for the other 2 weeks. This was continued for a total of 24 cycles, nearly 2 years spanning, and only in cycle 2 was TLS prophylaxis given in the form of oral fluids was advised and allopurinol at 100 mg per oral TDS. Response assessment was done by complete blood counts, comprehensive metabolic panel, serum immunoglobulins, and this was done once monthly for the first 3 months, followed by 4 monthly. Bone marrow aspiration biopsies was done at 6, 12, and 24 months. CT scans with contrast was done at 6, 12, and 24 months. This was done primarily only in patients who had extramedullary disease in the baseline. Sample size was calculated with an alpha level of 0.02, power of 80%, and VGPR rate of more than 45% based on previous ibrutinib and venetoclax rates. Subset analysis for CXCR4 mutation was done. Logistic regression models, association between baseline characteristics and attainment of VGPR was done. In the baseline characteristics, of note was that platelet count was less than 1 lakh, especially in the CXCR4 mutated subset of patients, and acquired von Willebrand disease was again found to be more significantly seen in the CXCR4 mutated patients. In results, they found that VGPR was attained overall in 42% of patients out of the 53% patients had a partial response, and 4% patients had a minor response, coming to a total of overall response of 100% and major response rate of 96%. When they further subdivided this into CXCR mutated and wild type, they found that although numerically the wild type had a higher VGPR rate of 50% as compared to 29%, this was not statistically significant. 50% was a partial response in the wild type, and in the CXCR4 mutated, it was 59%. In univariate and multivariate log regression analysis for VGPR, beta 2 microglobulin at more than 3 milligram per liter was found to be significant in univariate analysis. However, in multivariate analysis it was found to be significant with a p-value of 0.02. In adenopathy of more than 1.5 centimeters was found to be significant only in univariate analysis and not in multivariate analysis. The progression-free survival at 24 months overall in 50 patients was 76%, and the progression-free survival in CXCR4 wild type was 82%, in CXCR4 mutated type was 67%, with the two graphs not showing much separation. So although numerically there was difference, but equivalence was noted on further analysis. So time to next therapy probability at 24 months was 89%, and the overall survival was at 24 months 96%. The progression-free survival after end of therapy probability. So they further followed up these patients for 12 months, and the progression-free survivals after end of therapy was 79%. And in progression-free survival after end of therapy probability in CXCR4 wild type was 84%, whereas in CXCR4 mutated type was 71%. As you can see, there was not much separation of the two graphs. The progression-free survival after end of therapy probability in less than 12 months was 81%, and in more than 12 months was 77%. And they noted that in VGPR attainment, patients who had attained VGPR, the progression-free survival was as high as 94%. In those who had not attained VGPR, the 12-month progression-free survival after end of therapy was 69%. There was no significant variables between the baseline variables and the progression-free survival after Cox proportional hazard regression analysis. When we come to adverse events, so this is important, grade 3 and more adverse events were noted in the form of mucositis, diarrhea, cytopenias, and atrial fibrillation. And 3 patients had developed grade 3 or 4 ventricular arrhythmias. This caused the early termination of the study. 3 patients discontinued prior to this because of brain bleed. This was due to some other CNS disease which was not associated with Waldenstrom. 1 patient had a transformation to DLBCL, and 1 patient had a ventricular arrhythmia before that. So let's come to discussion. This is an all-oral, fixed duration chemotherapy regimen that was proposed. So the VGPR rate was reported higher than that for both ibrutinib monotherapy in the frontline setting and venetoclax monotherapy in the relapsed refractory setting. It provides a fast response with effective bone marrow clearance in the form that they noticed that patients who had more than 60% infiltration of lymphoplasmacytic cells in the baseline, after therapy, it came down to as low as 8%, and this was very early on in the therapy. And the addition of venetoclax might reduce the impact of CXCR4 mutation in the effect of ibrutinib-treated Waldenstrom macroglobulinemia. The cause for ventricular arrhythmia, they associated to underlying coronary artery disease, and they saw that these patients all had some high risk factor like hypertension, hypercholesterolemia, diabetes, obesity. They also postulated that maybe they had some underlying AL amyloidosis which was not picked up in the baseline. They have postulated that a sustained PFS will be noted at the end of therapy, but the true end of therapy PFS was only done for 12 months. So the reason they postulated this was because ibrutinib, venetoclax, when used in monotherapy, after the end of 2 years, when they discontinued therapy, most of the patients had progression within 5 months. So the patients did not progress till 12 months. They believe that they will not progress in future. This is the explanation given in the journal. And the reduced incidence of acquiring TP53 and BTK mutations was noticed in the combination therapy. They did this by doing a bone marrow at the end of therapy and noticed that these mutations were not occurred. So they believe that by addition of venetoclax, we might be reducing the incidence of mutations in BTK. But how feasible is this therapy in India? Let's leave aside the fact that ventricular arrhythmia is such a major concern happened in these patients. But the cost, considering the cost of both ibrutinib and venetoclax when given in combination, would be too high and unattainable for the exchequer or the common man's pocket. And neutropenia and sepsis is a major concern in Indian setting, especially in an OPD setting. If you are giving venetoclax, then you will expect some neutropenia. They have taken patients with ECOG of less than or equal to 2 and with very less cytopenia. So if we take patients without these concentrations, neutropenia might be much more severe and cause severe sepsis, leading to admission. Considering the events of ventricular arrhythmia, they have discontinued all studies which are ongoing and in future, which include ibrutinib and venetoclax. Instead, they are now postulating that pirtobrutinib, which is a non-covalent BTK inhibitor or other second-generation BTK inhibitors, can be used in combination with venetoclax for therapy in future. In critical appraisal, this was the drawbacks of these studies were it was a single arm study, the sample size was relatively small, VGPR and not PFS was taken as a primary outcome. They did not include patients with severe cytopenia or renal dysfunction, and it prematurely terminated study because of the ibrutinib induced ventricular arrhythmias. The duration of follow up was very short. In fact, only 12 months post end of therapy they had followed up, and the true end of therapy PFS was only done for 12 months. So this is, if we compare, although it is not fair to compare this study with other studies, as they are all not a head-to-head comparison of the other regimens, ibrutinib and venetoclax had a major response rate of nearly 96%. None of these studies have had such a major response rate. But definitely, this is not a therapy or practice-changing guidelines because even though this is one not a head-to-head comparison, and secondly because of the induced arrhythmias caused by ibrutinib. That's all. Thank you so much for this opportunity. I would like to thank Sanjeev sir and Kashyap sir for their guidance as well. Thank you so much.
So, Dr. Sanjeev, you can start with the comments on this article. You are muted.
Very nicely presented, Aishwarya.
Thank you, sir.
Regarding this article, it's a very costly combination, that is ibrutinib and venetoclax. Both the drug are individually very costly, but the kind of response that we are getting, the overall response rate of 96%, that is amazing. Definitely, just like in the Clarity trial of CLL, the combination of and most importantly, fixed duration, fixed dose therapy. That is important. Continuous therapy is not an option, not a way to go. And fixed dose therapy with fixed duration, that is the way to go. And I think it offers this kind of therapy for Waldenstrom patients. And the response with MID 88 negative patients, that is poor with a single agent ibrutinib, I think in those subset of patients, definitely the way to go is the combination therapy.
Okay, thank you, Dr. Sanjeev. I think in India, when we consider upfront therapy of Waldenstrom macroglobulinemia, most institutes, I think, have shifted to now a bendamustine rituximab based combination therapy, which is a fixed duration therapy, and people are quite comfortable in using bendamustine rituximab therapy for Waldenstrom macroglobulinemia. Obviously, as in chronic lymphocytic leukemia, these therapies, combination of therapies which have been used in chronic lymphocytic leukemia now are coming up in the treatment of Waldenstrom macroglobulinemia also. And already use of venetoclax as a single agent by the same author was done a couple of years ago, and he had shown that this benefits a subgroup of patients, especially those patients who have CXCR mutation, which is positive. Somehow in India, we do MID88, but we don't, I'm not sure how many institutes do the CXCR mutation testing done, because that is giving a poor response rates with the single agent ibrutinib based therapy. So obviously, when you combine venetoclax with ibrutinib, you are taking care of a poor risk group of patients who have both CXCR as well as MYD88 mutation. And this is a group of patients where obviously a combination of butane kinase inhibitor and venetoclax would have give a very good results. As Dr. Sanjeev has already said, this combination is a costly one, and we are not sure whether this would be possible in India or not. But fortunately, we have availability of generic version of ibrutinib as well as acalabrutinib. In this trial, obviously, combination of ibrutinib and venetoclax was used, and this trial was terminated prematurely because of the deaths of patients because of ventricular fibrillation. Now, generally, ibrutinib, which is a butane kinase inhibitor, causes more of atrial arrhythmias rather than ventricular arrhythmias. So even when we are giving ibrutinib in chronic lymphocytic leukemia patients, we always ask the patients to get a ECG done and get a blood pressure checkup done regularly. And both these complications can happen up to 25% of patients. And with the use of acalabrutinib, these chances of these complications are close to 2% or so. So now most people, even in CLL, has done away with the use of ibrutinib wherever butane kinase inhibitors are required. So people are using acalabrutinib rather than ibrutinib because there is not much cost difference between ibrutinib and acalabrutinib, though ibrutinib is cheaper than acalabrutinib. But if you look at the complications, then obviously the complication rates with acalabrutinib are much lower than ibrutinib. So in future, let's say if we say that this combination may be used in some of the patients of Waldenström macroglobulinemia. So obviously you will not be able to use a combination of ibrutinib with venetoclax. In fact, if you really want to use, then the combination would be acalabrutinib with venetoclax, even though right now we do not have the data in the form of a trial. But that would be a theoretical use of combination. And as Dr. Aishwarya said, that the trials of the second generation butane kinase inhibitor, which is the non-covalent form, pirtobrutinib with venetoclax, the trial is already on, and hopefully next couple of years we may get results, and those results, maybe better, or at least the side effect profile would be hopefully should not be acceptable with this combination. Now, the other question is that if the butane kinase inhibitor cause more of atrial arrhythmias, so why in this trial patients had ventricular fibrillation? And the reason for that is obviously not very clear, even though people were monitored with ECG and QT interval was monitored in these patients, and none of these patients who developed ventricular fibrillation had any prolongation of QT interval. They were not on any other medicines which are cardiotoxic, and both ibrutinib and venetoclax are not cardiotoxic directly, except ibrutinib, already said 25% patients may develop atrial arrhythmias or hypertension. So again, the reason for development of ventricular fibrillation is not very clear in this trial. This may be, by chance or by luck, sometimes, a random error which has happened. And the other thing which Dr. Aishwarya had mentioned, that many of the Waldenström macroglobulinemia patients can have underlying amyloidosis, which was obviously not investigated very actively. So if the patient had obvious signs of amyloidosis, only those patients were checked, but otherwise it was not looked at actively. That means no cardiac MRI were done in these patients. So that is a theoretical possibility that some of these patients may have underlying cardiac amyloidosis. And we know the patients with cardiac amyloidosis, they are prone to arrhythmias, and that may be one possibility, that if the ibrutinib is given to these patients, they may have developed ventricular fibrillation leading to death of these patients. But otherwise, this trial gives us a proof of principle that a combination of butane kinase inhibitor and a venetoclax, which is a BCL2 inhibitor, combination is probably the way to go in future for patients with Waldenstrom macroglobulinemia. With that, I think the journal is open to discussion, and I can see Dr. Reena Nair, I can see Dr. Hari, I can see Dr. Arun. So if they want to make any comments, Dr. Reena Nair, do you have any comments on this article? Dr. Hari, you are muted if you can. So Dr. Hari site has done the first CAR-T patient for multiple relapsed refractory multiple myeloma patients today. So congratulations, Dr. Hari, for carrying out the first patient of trial.
Congratulations, sir.
Yeah, first patient, yes, but it's a third patient on the trial. CMC Vellore and Apollo Hyderabad have we were third in the queue, so it was first at St. John's and probably, yeah. So thank you for that. As far as this is concerned about the trial, yeah, I really, it's strange that we should have a diametrically opposite kind of a side effect that we would otherwise encounter with ibrutinib. So it will be something that we need to look into as to why patients develop really ventricular arrhythmias. But otherwise, if you look at the data from chronic lymphatic leukemia, we know that the combination works very well. And probably it's something that I think the future trials will probably improve upon this, probably using the next generation, because acalabrutinib, the only advantage of acalabrutinib is its cardiac toxicity, I mean, improved cardiac profile over here. But we don't know why whether it will overcome the ventricular arrhythmias. So that's something that is, but otherwise it is very attractive option to be using for patients in Waldenstrom's macroglobulinemia. But I was just thinking, unlike a CLL where CD20 is not such an important target and combination of rituximab in combination with any of the ibrutinib did not work, I was wondering whether addition of that to this regimen would improve the outcomes, because Waldenstrom's macroglobulinemia is a little different in terms of the CD20 positive the status being there. And probably that might be another exploratory option that one has to look into. But this is still in its early phases, and I'm sure that we will see more of this in the future.
Yes, thank you, Dr. Hari. I can see a hand up from the ICER Tirupati.
Yes, I'm Shivakumar. I'm quite new here. So I like the paper on this combination therapy. So we work on NF-κB signaling and multiple myeloma and other signaling pathways as well. So I know quite a bit of protein tyrosine kinase and MyD88 connection in the context of hematological malignancies. So the ibrutinib was actually extensively studied by Lou Stout's group, Professor Louis Stout, who is the director of the NIH Hematological Malignancies of USA. There is, obviously, you people might know already that ibrutinib is not completely efficient. There is recurrence of tumors after ibrutinib treatment. And this BCL2 inhibitor is going to be toxic in one way or the other way. There was another paper showing that the ventricular BCL2 inhibition causes drastic decline in BCL2 levels, which is an anti-apoptotic protein within the ventricular muscle cells, causing heart damage as such. If not heart damage, BCL2 inhibition would cause other vital organ damage, because it is very, very important in survival of many cells. So therefore, as such, I don't know how reasonable it is to go with ventricular treatment for any therapy, unless if there's a dose requirement that there's a dose that would not affect the BCL2 levels in a healthy cell, in a vital organ. If such a dose is identified, perhaps it is worth trying it. But otherwise, there is a need for new drugs which selectively targets the NF-κB system, which is certainly involved in all hematological malignancies, in a way that you target the NF-κB system without blocking the whole NF-κB pathway, but specific selective molecular complexes that are operating in a disease-specific manner. Let us say CLL-specific NF-kB complex or myeloma-specific NF-kB complex. If you identify such specific complexes which are formed selectively in a disease-specific manner, we can develop drugs to target those complexes. We actually, in our lab, have identified a couple of such NF-kB complexes. For example, REL-A YY1 complex, which is frequently observed in multiple myeloma, and we developed a small molecular compound that in cell culture level clearly disrupts the REL-A YY1 complex in multiple myeloma cells and subjects them to apoptosis. So I would like to further collaborate with physicians to get primary myeloma samples to test the efficacy of the compound that we identified to further look at its efficacy on the on killing the primary myeloma cells and take it further. So that's about our study. Coming back to the paper, targeting BCL2, I personally don't think is a very good idea. Thank you.
Thank you, Dr. Shiva Kumar, for your comments. So, yeah, Hari, you want to say?
No, I'm just curious to think that the same combination was used in chronic lymphatic leukemia with great efficacy, and we did not have the same. And if you look at the profile of patients, perhaps they are the same in the older subset of patients. I'm just if we were to think that this is because of the BCL2 inhibition, then we should have encountered those problems in this in the CLL study also, which we have not actually. So I'm just wondering as to whether there's something else to this which needs to be explored.
I understand that, yeah. Whether it's a chance occurrence or depending on the size of the number of the patients studied in the CLL study. So whether it's a chance occurrence or in general, BCL2 is a very, if you touch BCL2, it's going to be toxic. That's my, as a molecular biologist and cell biologist, I can say that.
Yeah. So the only thing that I can see that is different in terms of having a lead time to introducing venetoclax to the entire regimen in the CLL study was that it was almost after 3 months after introducing ibrutinib into the regimen and then adding this thing. Whereas in this study, we have introduced venetoclax almost immediately, almost within 4 weeks of starting ibrutinib. So I wonder whether those things have an implication. That's those are the things that we can look at. Yes. Yeah.
Sure.
Yeah. So, Dr. Shiva Kumar, the venetoclax is now used in acute myeloid leukemia patients, in lymphoma patients, in CLL. So not only in lymphoproliferative disorders, it is also being used in myeloproliferative disorders. And as per our understanding, this venetoclax inhibits only the excess anti-apoptosis which is happening and not the normal apoptosis. And you are absolutely right. If you know, and the same thing happens with the tyrosine kinase inhibitors also. So people, when they develop tyrosine kinase inhibitor, at that time, the thinking was that in the body, there are so many tyrosine kinase activities which is happening. The cell require that. But fortunately, when the clinical trials were done, so the tyrosine kinase inhibitors were inhibiting only the excess or abnormal tyrosine kinase activity and not the normal one. And the same is true for venetoclax also. So it is not inhibiting the normal apoptosis kind of a process. It is only inhibiting the abnormal, and that's why it is a very important kind, important kind of a drug in the treatment of both myeloproliferative as well as lymphoproliferative disorders. And the safety profile is now very well proven with the venetoclax, both in CLL, in acute myeloid leukemia in combination with azacitidine, as well as in Waldenstrom macroglobulinemia.
Yeah, I take that argument certainly. Thank you, Dr. Pankaj. But in general, like Dr. Hari is mentioning, why would only in one disease treatment condition it causes cardiac damage, and why not during the other treatment regime? So that's an important question to consider. So why? How to explain that?
So yes, exactly. So that's what we discussed previously. That it is possible. This is not cardiac toxic. And it is possible that some of these patients have underlying amyloidosis of the heart, which is amyloidosis causes more of arrhythmias in the heart, and that may be a possibility, of some patients developing ventricular arrhythmias. And this percentage is low, but ventricular fibrillation is a life-threatening kind of a side effect. So that's why the trial was stopped prematurely. And the newer trial is a combination of, again, venetoclax with newer butane kinase inhibitor. So they are still keeping the venetoclax as one of the important agent, because single agent venetoclax has not been shown to be any cardiac side effects in any of the trials, whether it is acute myeloid leukemia or chronic lymphocytic leukemia or Waldenström macroglobulinemia. In the phase 2 trial, where the venetoclax was used as a single agent, on the basis of which the combination of this drug with ibrutinib is used, in that trial there was no cardiac side effects.
Okay.
So I think, do we see any questions in the chat box? Yeah,
No,
so
sir.
Dr. Arun has mentioned these patients, the autopsy could not be done. So that's why, if the sometimes, if you do the autopsy, so you can find out the reason for the underlying amyloidosis also. Dr. Sanjeev, you want to say something?
Sir, at our center, we at baseline we are doing MYD88 mutation, CXCR4 mutation, and TP53 mutation for all Waldenström patient, and we are doing the cardiac MRI for those patients for looking for underlying and according to that we are randomizing them to acalabrutinib, and if they are MYD88 negative, then only thinking of more aggressive treatment. For MYD88 mutation, just acalabrutinib 100 milligram BD treatment has to be considered. So I think with that we can find out those group of patients in which we need aggressive treatment.
Okay, so that's important information that your lab is doing the CXCR mutation also in all these patients of Waldenström macroglobulinemia. Okay, I think now we can go on to the next phase of this journal club, and I think the next presentation is, so thank you Dr. Aishwarya and Dr. Sanjeev. So the next presentation is by Dr. Shiva Kumar. You just listen to him. He's Associate Professor at Indian Institute of Science, Education and Research, Tirupati. And he would be discussing about targeting the NF-kappa B system in multiple myeloma towards novel mechanistic insights and therapeutic approaches.
I'm sorry, Dr. Pankaj, there seems to be some miscommunication. I was asked to first prepare a recorded talk and then asked to make a live presentation. And then eventually it was decided that they dropped me out for today, and next time they would add me. But I can briefly explain what I'll do.
If you can just briefly without slide, if you are
right. I'll be happy to do that. Absolutely.
Yeah.
So
sure.
like I was mentioning a while ago, so essentially we focus on the long-term interest of the lab is like we work on multiple myeloma, and we want to identify the protein-protein interactome that is selective for multiple myeloma cells compared to healthy plasma cells. So that's the idea. So if we know that the protein-protein interacting network that is important for the survival of multiple myeloma cells, then we can develop strategies to target those protein interactions happening selectively in multiple myeloma cells compared to healthy plasma cells. So with that idea, we previously worked on the NF-κB system and found two interesting complexes formed by NF-kappa B more frequently in multiple myeloma cells than normal healthy B cells. So one such complex is REL-A YY1 complex. These two proteins, they are required to suppress pro-apoptotic genes in multiple myeloma cells. We collaborate with Professor Leif Berg-Sagel at Mayo Clinic to obtain myeloma cells from them, cell lines as such actually. And we found that the REL-A-YY1 complex is frequently found in many of the myeloma cell lines, human myeloma cell lines, as well as in primary patient-derived multiple myeloma cells as compared to normal B cells. And then when we disrupt the formation of the REL-A-YY1 complex, essentially to prevent them from coming together, when we do that, a couple of pro-apoptotic genes such as BIM, their levels goes higher. And BIM is very, very toxic to myeloma cells. In the moment there is a little bit increase in the BIM, the myeloma cells would die. So, and knowing that the REL-A-YY1 complex togetherness is required for repression of the BIM gene and survival of myeloma cells, we went ahead to develop a peptide inhibitor that sits in between the REL-A-YY1 complex and prevents them from coming together without affecting any other proteins in the cells. So it's selectively blocking the REL-A-YY1 interaction, that peptide that we designed. When we overexpress such a peptide, which is largely selectively disrupting REL-A-YY1 interaction without affecting the individual functions of REL-A and individual function of YY1, just preventing them from coming together, that was sufficient to de-repress the BIM gene and increase in the BIM gene levels, cause the apoptosis of myeloma cells. Likewise, we also have identified another complex called HDAC4-REL-B complex, which most myeloma cells, regardless of the oncogenes that oncogenic mutations that originally caused plasma cell malignancy, regardless of the which genetic groups they fall into, most myeloma cell lines were found to be addicted to HDAC4-REL-B complex. Again, the HDAC4-REL-B must interact with each other. And this complex was again found to be more frequently formed in myeloma cells, primary myeloma cells, compared to normal healthy B cells. Again, we disrupted the HDAC4-REL-B complex with a peptide inhibitor so that they do not come together, but REL-B and HDAC4, they can still function for their respective other functions. The moment we disrupt the formation of HDAC4-REL-B complex, the BIM and BMF genes, again, they go higher, pro-apoptotic genes, and they cause myeloma cells apoptosis. And in xenograft studies, we showed that the disruption, the peptide that disrupts the HDAC4-REL-B complex, when we overexpress it, that is sufficient to kill myeloma cells and prevent tumor growth in xenograft studies in the mouse models. We also tested that in primary myeloma cells that is required for their survival. So going ahead from there, we modeled with the help of a computational biologist, we modeled both REL-A-YY1 complex structure, HDAC4-REL-B complex structure, and based on that, my collaborator, computational biologist, he designed several small molecular compounds which could potentially disrupt REL-A-YY1 complex and HDAC4-REL-B complex. And we went ahead and tested, screened several of those compounds based on a FRET assay, wherein the fluorescence comes out only when the two molecules interact, and when they are disrupted, there is no fluorescence observed. So that is, I'll detail about FRET assay, etc. in the next presentation whenever I get a chance. Without slides, it's not easy. In any case, if they bind together, there is some fluorescence observed. If they do not bind with each other, fluorescence is lost. That's the readout. So we screened a lot of compounds that could potentially disrupt the REL-A-YY1 complex and found one of the compounds to be very effective in disrupting the REL-A-YY1 complex. And we further tested it in myeloma cells. That compound is very effective in killing the myeloma cells by disrupting REL-A-YY1 complex. So the next step is to test the compound efficacy on primary myeloma cells, and also its efficacy to actually disrupt REL-A-YY1 complex, but not anything else. So the idea is to develop drugs that are highly selective in nature in disrupting a specific subset of NF-κB complexes, so that we eliminate a lot of toxic side effects, like, for example, the side effects observed with BCL2 inhibition. You would expect that BCL2 inhibition, or if you block the whole NF-κB pathway, which is required for BCL2 expression also. So the moment there are so many NF-κB inhibitors in the market, they did not make it to clinic because of the exact reason that NF-κB is required for the survival of all normal healthy cells. The moment you put that drug in the patient, there's a lot of toxic side effects. To eliminate such toxic side effects, we want to kind of still target NF-κB, but a specific subset of NF-κB complex that is selectively formed in or more frequently formed in multiple myeloma cells. So with that idea, we kind of developed this compound so far. We want to test it in primary myeloma cells and then animal models, and then move on to clinical studies and so on. Yeah.
Thank you, Dr. Shiva Kumar. That's a excellent lab work which you are doing, experimental work. Just a question: we have NF-κB like bortezomib, carfilzomib, and ixazomib in the market, and we do use all these drugs, and they are very effective against the myeloma. In fact, the remission of these patients and the survival of these patients have greatly increased after the introduction of NF-κB inhibitors since 2003 onwards. So it has been 20 years we have been using NF-κB inhibitors, and they are one of the backbone of treatment of multiple myeloma these days. So did you check with these agents?
Right. So bortezomib is not selective to NF-κB. It blocks the proteasome function. So anything that depends on proteasome-mediated degradation will be blocked. And I agree that bortezomib has been very well used in the clinic, but there is toxicity associated with that as well. So our idea is to inhibit the NF-κB pathway, at the same time curb the toxic side effects possible as much as possible. That's the idea.
Okay. Thank you. I just got a message from Dr. Subhash Verma, and he has shared one abstract where ibrutinib, patients on ibrutinib who were monitored with the continuous cardiac monitoring, almost 88% of them had premature ventricular contractions. And the conclusion of that abstract is that ibrutinib do causes ventricular arrhythmias also. So it is not only the atrial arrhythmias, it also causes the ventricular arrhythmias. Again, pointing out that in the journal article which we discussed, a combination of ibrutinib and venetoclax, probably the culprit is ibrutinib and not venetoclax for ventricular arrhythmias. Thank you, Dr. Verma, for that. Arun, you have raised your hand.
Yes, so this was a question to the NF-kappa beta inhibition concept. I just wanted to know, has the researchers looked into the physiological role of a constitutively active NF-kappa B in the human body? And when you non-selectively inhibit that pathway, how do we target it to myeloma cells specifically? Because there will be some collateral damage if you do a pan NF-kappa B inhibition.
Absolutely, that's exactly, Dr. Varun, that is exactly what I'm saying. If you block the NF-κB pathway as such, NF-κB being central to many processes in the human body beyond the immune system, so there will be toxic side effects. And bortezomib, although it is not selective to NF-κB, it has even broad spectrum inhibition of other pathways, will have toxic side effects. And of course, the clinicians will know how much dose to give to minimize the toxic side effects. Still, you cannot you cannot prevent the side effects. So therefore, it is advisable to come up with targeting selective complexes that are formed in a disease-specific manner. If you identify a protein-protein complex formed more frequently in myeloma than other healthy cells, and if you develop strategies to target such a molecular complex, then you expect that there will be less toxic side effects and at the same time efficient killing of the cancer cells. That's the idea on which we work. Okay. So as I said, the REL-A YY1 complex, which is a NF-κB based complex formed downstream of the NF-κB pathway. When we target that complex, we are not affecting the entire NF-κB activation, the other angles of NF-κB, only this REL-A YY1 complex. So therefore we hope that such a strategy will have lesser toxic side effects, but at the same time, they would kill the myeloma cells. That's the idea.
Okay.
Did I answer your question, Dr. Arun?
Yeah, thank you. Thank you.
Yeah.
Okay, thank you, Dr. Shiva Kumar. So now it is time for an online quiz. So may I invite Dr. Arun for the online quiz?
Yeah, is my screen visible?
Yes.
Yeah, so welcome to today's myeloma quiz. As we go about, the myeloma quiz is usually a question on the trivia of the topic being discussed, and then we do have 4 questions on the journal club, which is discussed. So, without any ado, this is my first question. This is about the legendary Swedish physician Waldenstrom. Which of the following would be the incorrect statement? Is my question. So we get to know about this person if you look into this question. So the options are whether he studied organic chemistry with Hans Fischer, the Nobel Prize winner first in the University of Munich, whether he did simultaneous work on intermittent porphyria and chronic active hepatitis and carcinoid syndrome, other options, and did he initially describe cases of Waldenstrom macroglobulinemia as purpurea hyperglobulinemica, as we know today? So you have to choose the incorrect option here. You have 30 seconds to register your answer. The fastest fingers first gets the prize. The next 2 questions are based on the study which was discussed here in the Journal Club by the Castillo et al. Group on ibrutinib and venetoclax. So there are 5 options here. You have to choose the incorrect statement again. All treatments were administered in an outpatient setting. Venetoclax was introduced from cycle 2 only. GCSF support was permitted only when the ANC dropped to less than 500, and did the study do aspiration biopsies at baseline and at subsequent period, or were all these statements correct? I move to my third question. That's based on the adverse events and the efficacy which we saw with this trial. So the 3 options are which of these, the third question is about the incorrect statement with respect to the trial results. The most common grade 3 adverse event was neutropenia. 2 grade 5 adverse events were reported in the trial. The responses were pretty fast. The median time to minor and major responses are shown here. We had 3 cases of clinical TLS in the trial, but most of them, none of them required an RRP, and they were managed well. The last 2 questions are based on the topic, which is Waldenstrom's here. So we discussed at length about the MID mutation, which is the L265P mutation, which is not a common association with this mutation. Is it splenic marginal zone lymphoma, IgM myeloma, maltoma, or IgM amyloid? Although we know Waldenstrom's is the prototype of the disorders where you would describe these mutations and prognosticate patient as well. My last question is on the IPSS system, which is the prognosticating scoring system exclusively used for Waldenstrom's. You have to choose the incorrect statement again. The IPSS is to be used only for patients who require treatment for Waldenstrom's. Does serial measurements of beta-2 microglobulin help us in assessing Waldenstrom's patient on therapy? Is age the most powerful predictor of outcome in Waldenstrom's? And whether LDH and an IgM level more than 5,000 predict early mortality in Waldenstrom's as per the IPSS? So as the organizers would compile the results, I would discuss the answers to these questions. So this is about Jan Gustav Waldenstrom, a Swedish physician. There's a beautiful obituary written by none other than Robert Kyle on him. It's a freely downloadable article in Blood published in June 1997. I think everyone must read about it. So it was interesting to know that his associations with a lot of polymaths, which included Hans Fischer as well, and he was inspired by many, and he inspired more generation to come also. He worked a lot on other entities like porphyria. His PhD thesis was on that topic. His description of carcinoids and chronic active hepatitis for the first time in literature is also very much appreciable. But what is important to know is the entity of purpura hyperglobulinemica is a benign entity, which is also an IgM associated purpura, but it is not a clonal disorder, and it just has only eponymical significance with no treatment required whatsoever. With regards to the next 2 questions, which was on the trial which we discussed by Castillo, we should know here that the the three statements are true here. That is, outpatient administration of Ibru and venetoclax, which was introduced in the cycle 2 only. The GCF support was permitted in the study, but that was when the ANC dropped to less than 1,000. They did not wait till the ANC dropped to less than 500. So you have to read between the lines to answer the question here. This is another trigger here. There were no cases of clinical TLS, although there are a lot of biochemical TLS when you use ibrutinib and venetoclax, despite the ramp up and the hydration and the allopurinol. But there were no clinical TLS in this case in the trial. So the last option was incorrect. It's important to note that sometimes for the clinician, the differential between an IgM myeloma and Waldenstrom's can be tricky, although there are many parameters to differentiate between the two. An IgM myeloma classically doesn't have a MYD88 mutation. Less than 10% of marginal zone lymphomas and maltomas have MYD88 mutation. Almost 80% of IgM amyloid would have MYD88 mutation. It's important to know that the IPSS, which is a prognosticating system in Waldenstrom's, is a bit different from other IPI systems of non-Hodgkin's lymphoma. So as you can see, it has age, hemoglobin, platelet count, beta-2 microglobulin, and a monoclonal IgM here. But it is when the monoclonal IgM goes above 7, and there is no LDH here, very peculiarly, that IPSS has nothing to do with the LDH. So that was the incorrect statement here. And this is to be applied only for patients who are on treatment or requiring treatment for Waldenstrom's. Thank you all. I would request the organizers to announce the winner if they have compiled the results.
Yes, sir. The winner is Dr. Harish Chandra Yadav, and he's from NSC Government Medical College, Khandava.
Congratulations. What awaits you is definitely a voucher and a gift as well, and a certificate from us. Please do participate and keep the quiz going on. Thanks for your participation. I now hand over the podium to the organizers for the concluding remarks.
So thank you, Dr. Arun, for this quiz, and congratulations to the winner. Today, actually, our international faculty, because of some urgent work, could not join, Dr. Shaji Kumar. So he has promised that in the next Journal Club, which is going to happen on 22nd of March, he will be there, and Dr. Nikhil Munshi would be there on 26th of April. So we are looking for the next Journal Clubs. If anybody has any comments, Dr. Reena Nair, Dr. Hari, anybody else? Any last minute comments? Otherwise, we will close this.
Sorry, Pankaj, for not answering when you asked, but there was a technical problem. Next time I'll be more careful. But it was a great. I thought you did an excellent job today. And so even if we have or we don't have collaborators from outside, I think the whole group did a fantastic job. I enjoyed the Journal Club today.
Yes, thank you, ma'am. Thank you. And the next image myeloma meeting is in Kolkata. On behalf of Dr. Reena Nair, I would all invite you to block the dates and start working on some of the abstracts on myeloma, and as well as on amyloid and Waldenstrom, because there would be separate prizes for Waldenstrom and amyloid, as well as for myeloma. So with that, I thank you all who have joined for this Journal Club, Dr. Sanjeev, Dr. Aishwarya, Dr. Hari, Dr. Reena Nair, Dr. Uday, and our technical team, Anshika, Priyanshi, and all those people. And special thanks to Dr. Siva Kumar from ISAC Tirupati. And we are happy that, you know, the experimental the people who are working on the labs and experimental, they are joining with the image, and so hopefully to look for more collaboration. And thank you very much again, and we look forward to all of you in the next Journal Club, which would be held on 22nd of March at the same time, 5:30 p.m. Thank you very much. Take care. Bye-bye.